All right. Hi, everybody. My name's Justin. I run the WMS affiliated VTC Wilderness Medicine Journal Club series, and this is the September session on wilderness medicine ultrasound. We are joined by one of our fellows here, TJ Malik, who's going to be helping me host the session and run the Journal Club discussion sessions. We have two presenters today. We had initially discussed doing a third article, and I'm happy to talk about it in more of a relaxed setting if anybody wants to go through it. But formally, we're going to present two articles. First off, one of the article authors and one of our faculty here at VTC, Carver Haynes, is joined us here for our first article. And Sarah, that is your article. I'm going to do my best to kind of stay in the background here, let TJ and our article authors and presenters run the show. Otherwise, I'm going to mute myself and take it away, TJ and Sarah.
All right. Yeah, so we had this great article by people we know here in the program about ham radio. I thought it was incredibly interesting. Sarah, you want to take us through it a little bit?
Yeah, absolutely. So this was an excellent study. And when I first read the title, honestly, my thought was, I'm really bad at physics. I don't know anything about ham radio. I would never even know how to start to do this. But then as you read on, like they got everybody set up with the equipment that they needed to do it. So the physicians didn't necessarily have to understand how ham radios work or make the equipment or make it work. They set them up with the equipment. So the point of this study was standard transmission of POCUS versus images versus a radio transmission of the POCUS images, and then a side-by-side comparison of the image quality, because you can transmit, especially in a remote area, you can transmit. If you bring the fidelity down a little bit and transmit over the radio, you can get it sent using less data bytes than if you did it the standard way. And side-by-side comparisons, they were not dramatically different to my eye or in the side-by-side official comparison. So I thought this study was brilliant, really, because I worked before I went to medical school, and I was out in Dutch Harbor, Alaska, and even just trying to send de-identified butterfly images over our Wi-Fi and our text, I mean, it would take 45 minutes for like a very simple short thing to go. So this actually, I think for remote places that have a POCUS capability, this offers a significant benefit and significant potential for transmitting these images. And I thought it was a really well done study.
That's interesting about your experience in Alaska. I wonder, like, what kind of situations or like indications for sending images you found during your time there.
Absolutely. I was going to bring that up too. I mean, it would be several incidences, especially during COVID, of like cholecystitis and, just like trying to get that wall thickening. And even breast images. I had to be talked through that because I've never ultrasounded a breast before, but somebody had discovered a lump and we're in the middle of COVID, and do they want to fly 3 hours from the island to Anchorage and then have to quarantine for, at the time, 2 weeks when they get back? Like that's a big deal in a working human being who's a parent and has responsibilities. And so literally I had a doctor over an analog phone talking me through how to do the ultrasound. And then I kind of did ultrasound video the way they wanted. And then the butterfly actually is a really nice alternative also, because depending on how many people were on the network, like sometimes it would go actually quite quickly. And if I screenshot, it goes way quicker, but the videos take a little bit longer, but yeah, so like to determine whether or not somebody needed to travel all that way to get a biopsy, to a lot of gallbladder pathology, and even lung ultrasound videos, or I just do like a basic echo and a basic lung in COVID. or like if we're worried somebody has a PE, like a very basic echo to see,
There's
if
like
you
right
can
heart
see.
strain and things. Oh,
Yeah,
that's
yeah,
very cool. I appreciate that because I've been thinking when I read this, I was thinking about like situations in which, and I was like thinking like in a rescue situation, but like rural medicine, definitely, I can see that being very, very useful.
yeah. And even so, like even in a even in I mean a rescue situation like on Everest, say you have this and you need to, you want to transmit somebody's lungs, like how bad is their HAPE, or their, and you want to transmit images of their lungs to somebody. I think that would be reasonable. And gallbladder attacks happen to young healthy people too.
Hmm.
So you could have somebody trying to climb Everest who suddenly is like, oh my, I've got this terrible right upper quadrant pain, I feel like I'm going to die.
Yeah,
And
absolutely.
yeah,
Absolutely.
and so I do think, I do think, but if I had this and somebody showed me how to use it, I would have been, I'd be all for that.
Absolutely. There's a question submitted in the comments. Any uh, input, insight on the battery performance, or can we extrapolate like what would happen in cold situations or in extremes of heat or cold on like battery life or the like fidelity of this system to transmit images?
That is a really great question. Um,
Yeah, I don't know. I'm sure there's
I
probably
see
like
Carver just
generic.
unmuted himself here.
Yeah, so really
Thank you,
all it
Carver.
needs is really all it needs is the audio signal to transfer the images. So as long as your radio has enough battery to work, it really shouldn't affect it. Definitely battery management is something you want to keep an eye on when you have a radio and that's your only source of communication. But as long as it can transmit an audio signal, that's all it needs to work because it basically encodes these images as a series of tones and then decodes those tones at the other side back into an image.
Yeah.
Um, we didn't test it in other situations, but it could even be used in like cave rescue because cave rescue, there's no cell service, there's no radio service, there's no GPS, there's nothing at all. Um, but what they do is they'll run old like military hardline handheld phone sets, and they'll just run miles and miles of phone line cable through these caves, and all it is an old, uh, corded phone setup with no special features. All it can do is audio,
Hmm.
but you can theoretically send these images over that as well.
Hmm.
So
Hmm.
it doesn't have to be radio frequencies. You can use the same encoding, decoding through analog phone lines as well.
Correct. So if you're, say, in a high Nepalese alpine village that has phone service, but maybe they don't have internet there, if you could get an audio signal out, you could get images out.
Very cool.
And
Very.
with and to play to like the cold temperatures and battery in expedition environments, anything that I have that is battery based, I mean, we're talking from my headlamp to my satellite phone to even my butterfly ultrasound, I keep in pockets in my vest close to my body.
Mm.
So I just assume, especially if in extreme cold environments like Alaska can sometimes be, I think that uh, anticipating, you have to anticipate that the gear is going to perform differently. The tourniquet, the windlass might break if it's too cold. So even like if I was in an expedition environment where I might anticipate using a tourniquet, I would have that close to my body too. I wouldn't just have it hanging off my pack, because some of these things they don't like to be cold. And I would say any electronic, I would keep close to my body.
That's a really interesting point, important point. Um, One thing I was curious about was the encoding protocols. You mentioned that you used you tried a few different encoding protocols. I was wondering if you found anything interesting in that process when comparing the different protocols and whether you felt like the quality gained by the slower transmissions, were they worth it or was it negligible and it's better just to do the faster option?
So that's one of the things we looked at. We encoded the transmission for the images takes anywhere from 30 seconds to you can go up to a couple minutes if you want it to be a really high quality image. The nice thing about ultrasound is it's a lot of grainy black and gray stuff anyways. So when you add a few extra little, artifacts, black and white grain on it, it doesn't really change it a ton. So we did that, and basically there was no difference, no statistical difference between the lowest quality, sending it for like 36 seconds, versus sending it for, 240 seconds, couple minutes. The viewers couldn't tell a significant difference.
So
which is
probably use the faster one
life-changing
then.
time.
I'm sorry, Sarah.
No, I agree. I mean, that's life-changing time from even the butterfly.
Yeah. So it's probably better just to go with the faster option because the difference is negligible.
Right.
And then you mentioned in the article there was the study found like a 3.9% decrease in the transmitted image scores. I know that it's probably unlikely to be clinically significant, which you make a note of. But I was wondering, are there any things that you guys consider that could decrease that number, reduce the interference?
Well, I mean, at its nature, you are basically taking a high quality image from a phone, and you're basically downgrading the image quality to compress it and send it over this very, very slow bandwidth media. So really, it just comes down to image compression, and whether that's an acceptable use for what you're sending varies. For ultrasound, it seems to work fine. We did a few tests with like sending EKG tracings, and at the lowest quality, the 36-second compression, it was definitely hard to see like all the small boxes. So that would be a case where maybe, a 240 second transmission that has a lot higher quality might be beneficial.
That's excellent. Very, very interesting. One of my last questions, unless anyone wants to throw anything else in the chat here. The study mentioned some concerns over privacy and the fact that transmitting these over the internet, over the radio frequencies could allow for the release of protected health information. Is there any steps that you guys have theorized or anything we could do to reduce the risk of privacy concerns?
So that's definitely true on anytime you're on the radio, which is a big concern for rescue radios in general, because people are talking back and forth about patient rescues or status. There are radios that have a digital encryption, so a lot of EMS agencies are moving to encrypted radio frequencies now. That could work fine because it's still just transmitting an audio signal, so it would still work, but it could be encrypted. But that's definitely something you need to take into mind whenever you're on a rescue scene, because 90% of the time everyone just has blister pack radios from Walmart or whatever unencrypted collection of radios the rescue team has or uses. So you definitely want to always be mindful of what you're sending, either verbally or with encoded images over the radio waves, which are open to anyone to snoop on.
Is there any environment where obviously other than space, is there any environment you envision where it wouldn't work for whatever reason? Like whether that was weather interference or...
I mean, radios for sure are interfered by objects, trees, weather. Really, the key is making sure you have a good audio connection, regardless of whether that's a radio or a cave hardline or some other communication source, a landline. As long as you have a good audio signal back and forth and you can decently hear another person, there's a good chance you'll be able to get those images sent back and forth.
Okay. Like I was just trying to imagine like over a satellite phone.
That would probably work. If you have a satellite phone, there's also a good chance you can send data over that satellite phone too. So that might be an easier option.
Elon Musk might be interested in talking to you about this.
GPS beacon that we take on any adventures, we're thinking like, oh, we're going to be outside of cell phone range, and that seems kind of hindsight when you really had one, but it does have options for a limited amount of data, and it is based on satellite. And there are different, similar to cell phone carriers, there are different bands of satellite coverages that all have maps of their coverage. But basically, if you can see sky, you've got coverage, and it depends on how much you want to throw down for what kind of package you want. And as to radios, if you're talking like VHF versus 800, you're limited by line of sight, but it works really great in cities, and it really hates trees. And VEHF, while on the lower tech of things, will carry forever and really hates cities and really loves trees. They each have their trade-off, but for whatever you're wanting to throw down, if you've got clear view of the sky, you can get a satellite puck that you can get data.
Mm-hmm. And
one thing we
even
were kind of looking at this for was really that like last mile communication line where, you know, the person up on the top of the hill at the rescue base station has cell service or satellite phone service, and you're down in a valley rescuing a patient. You just need to get that image to the person at the top of the hill, who then can pass it on to whoever they need to. Or you just need to get it out of the cave to the entrance of the cave, and then someone else can pass it on via text message or satellite phones or other communication options.
Excellent.
Sarah and Carver, have we talked about how the actual process works?
No,
no.
I can find a photo and share my screen. There we go.
Nice.
Can everyone see that image?
Yes.
Yes,
Okay.
we can.
So the way it works is you have any image on your phone. In this case, we're using POCUS images from a butterfly ultrasound, which automatically get downloaded to your phone, or you can save them to your phone. But it could be an image of a person's busted leg or something else going on, an EKG tracing. You take that image. You can use, there's a couple different apps for iPhone, iOS. Basically, SSTV is the protocol, slow scan television. It encodes that image, so it scans the image line by line and takes each pixel or chunk of pixels, which is why it downgrades the image a lot to make it smaller, as a series of tones. Then what it does is this is a cable that takes the speaker output on the phone and puts it as a microphone input into the radio. Not necessary, but it does increase the quality. So you could literally just hold your phone playing up these series of sounds to the radio mic while you're holding down the button without the cable in between, and it would also work, but more subject to background noise like waterfalls and trees and birds and people talking. So then it basically, the first thing it sends is a series of pre-tones, which basically says, hey, I'm transmitting an image now, and this is the encoding method I'm using. So Robot 36 was that 36 second one we were talking about. So it says, hey, this is the encoding one. The other radio receives it. And again, it's just hearing sound, and it's just playing that sound through the microphone cable. And again, it could just come out of the radio's microphone, and you could hold your phone up next to it. But again, a little bit more audio interference. So if you have a cable, it's basically just capturing that sound, putting it into the phone's mic jack. So the phone is literally, again, just hearing a sound, and you can actually see the little sound waves coming in down here. And then it takes those series of pre-tones, and it says, okay, I'm receiving an image now. So it knows it's starting to receive an image, and it knows what encoding method it's using. So it starts decrypting that image or decoding those series of tones back into the pixels. So, and then at the very end, there's an end tone. So it knows it's done with the image, and then it automatically can save that image to the phone.
Yeah, I love how nicely this comes together. So on the left side of the image, we have the audio output coming from the phone, but on the right side of the image, we have it's going through like a mic port, or is that still the 3.5 millimeter jack?
Yep. So these are the same. These are identical on both sides. So
okay.
it's listening and receiving at the same time. So you could use phone as a. Normally, what you plug in here is you plug in like one of those earpieces where you could both listen and talk through, or one of those chest-mounted mic receivers that you can listen and talk through. So it can transmit both outgoing and ingoing signals.
Okay.
But this is just an adapter that converts that to a phone's 3.5 millimeter jack.
Interesting. Yeah, a totally like workable system there.
Yeah, biggest thing is you kind of have to have those apps pre-downloaded on your phone ahead of time, because we're assuming you don't have cell service. Otherwise, you just text the image. So a little bit of preparation.
And so Drew Peterson in the chat box said, officially the coolest thing I've seen all month. And I cannot agree more. I mean, this is brilliant. Like having having used the butterfly, having used radios, having used the earpieces, like never in a million years would I have imagined that something like this was even possible. And I am just so impressed.
And I like how you make you put the historical note in there about like this is how the images from the Apollo moonwalk were transmitted, and I think that's
Right.
so cool.
And for
Can we
those of
talk
you who
about
didn't
the?
see,
Oh yeah, there's
these are all the
perfect
pre and
cover.
post. These are all the pre and post images. So
Yeah.
all the A's are the pre images. So those are the stock images right from the butterfly ultrasound on the phone. The B images are the ones after being transmitted couple miles via radio.
Oh, guest appearance! Look at this.
Oh yeah.
Can we talk about the different settings and distances and like obstacles that you kind of tested to show that it can work in different settings?
Sure. Let me see if I can pull up something for that. Can everyone see 9 photos that are all the same image?
Mm-hmm.
Okay. So these are the ones where I don't have the key with me, but these are the ones where we tried different transmission protocols. I think the fastest one was up here at the top left. And you can see the middle E is the one from the stock butterfly ultrasound. So if you compare just A and E, you can definitely see kind of down here in the darker area how there's a little bit more graininess, pixelation than there is on this one. So these are all using different encoding methods. These last 3 are different distances. So G is 1 mile, H was like 3 miles, or 5 miles, and then I was 5 miles, but we were having the person like drive through a city with like skyscrapers and under bridges. And you can see that's when their image really started to degrade. You're getting all these kind of green artifacty lines. That was kind of just to see what a worst case scenario would look like.
This is very impressive. Like these images are, I mean, the differences are negligible. You know, beyond the worst case scenario that you guys presented. I'm terribly impressed. It's amazing that that the encoding decoding process can do it with such fidelity.
Yeah, it's very
And
interesting.
A almost looks better.
Yeah, yeah.
A almost looks like it improved the like sharpness of it.
Oh, hold on. But I'm not sure if I'll be allowed to ask this one. I'll be quick. Any other settings you'd be interested in checking further? I think you mentioned that it was usually like a warm, sunny, cloudless day, and you had mentioned
yeah, I mean, it'd be interesting to see in like less good conditions, longer distances, more obstructions, like how useful it is. We were kind of again looking at this as kind of that last mile communication method where you just need to get it to a point where there is cell service. You're not necessarily getting it from the wilderness to the hospital, you're getting it to the rescue base or the person standing on top of a hill with a cell phone or something like that. But there's definitely potential for looking at this longer distances. It's definitely been used like that in the past because that's how they transmitted images from the moon back to Earth. So theoretically, as long as you have a good connection, there's no limitation on distance. But for a practical setting in a rescue environment, that might be something to look into. It also might be something to look into of other types of images because again, like I said, ultrasounds are kind of grainy, staticky images anyways, so they have a lot of tolerance for a little bit of extra noise.
Mm-hmm.
So if you were gonna wrangle up a team to provide a follow-up study, what would you like to look into next as another step?
I mean, I would probably do longer distances. One thing I really like to look at is just kind of sending these through like miles and miles of a cave hardline because I feel like with satellite phones and Starlink internet, there's getting more and more connections in the backcountry, and this will probably be less and less useful. But caves are still that one location where there are 0 good options. Radios don't work more than around a corner. There's no GPS, there's no satellite, and people are still laying wire to transmit audio.
So Aerial Recovery Group does a lot of humanitarian aid. Like they were in Hawaii the day after the fires, 2 days, 3 days before FEMA. They were in Morocco, but they use Starlink satellite cell phones, and they send physicians and medical crews. So if you ever want to talk to any of them and see if they want to test it for you, let me know.
Cool. Sounds good.
Any questions, or has anybody ever tried this before other than Carver?
I'll post a link in I made a separate thing that's outside the paper of just like, if you want to do it, how to do it. I can post that in the chat.
Oh, that would be excellent.
Mm-hmm.
Any questions that anybody in the audience has on possible implications or questions for the author in general?
Yeah, it's such a treat to have the authors of the paper with us to discuss. It's excellent. Thank you guys so much.
No problem.
So there was another article that I almost chose that could also be, I think, interesting. I don't know if it could be combined or just another way of transmitting or extending radio signals. I think I put it in the further reading section in the Google Drive, but it basically, as they were mentioning, radios can be obstructed by poor weather, like more severely limited signal if you're in a canyoneering setting, which is what this study assessed. But they're using drones, which is with what's called a radio repeater, or essentially it's like a router almost for your internet, and it'll boost the signal further to extend the range. Or what this study does is, like, they had the radio transmitting from somebody in a canyon, in like a ravine, with the drone with the repeater directly above them, and then they were able to send the signal out, whereas before, without the repeater, it just won't go outside the walls. They also do the same thing for like the opposite for the receiver down in the canyon, and just having the drone go to like above it. I think it would be kind of interesting if there's a combined way to do this. You could possibly use this to send your signal further. Do you think that's at all something that would need to be combined, Carver? Do you think that just having ultrasound transmission capabilities this way is enough?
I mean, anything that increases your radio range definitely would increase the ability to use this process. So that's kind of a cool way that you could do that, having a way that you can repeat it off something up in the air to get it a lot farther than you could otherwise.
Yeah, I'd recommend reading it. It was pretty straightforward. It's just like a cool topic to read about. It wasn't really any deep scientific, robust data, because it's literally like, hey, radio, we didn't have signal, and now we do have a signal. So I was just like, well, it's just cool to read about. But it was like 100% effective every time. All they had to do was get within a certain distance of the receiver or of the transmitter, to send it further. And it was just really cool to use. But that gets into issues which is somewhat common throughout the states. I don't know about other countries, but if you're in a national park, or if you're in certain state parks, there's rules against drones, and even the search and rescue teams are often unable to use them. So I think there's a constant progress towards maybe getting that to happen, but then you get like the lay people, the stubborn people, just want to get a cool photo that would be taking advantage of that. But I think it would be pretty cool to see. And I know there's a lot of SAR teams using drones more, and that's another reason that they could implement it.
Yeah, it's a cool application of drone technology. Very cool.
And there's also been uses of, and we talked about it last month, but same drone could be used to, like, on your search and rescue search pattern. They've found victims. There was a false report, but it sounded cool until you realize it was a false report, where it was like guiding the person down, or like wiggling a little bit to confirm that the search team found the victim, and that was actually found to be false. But the capabilities of drones, and then the capabilities that this could lead to with transmitting to like your medical director or your doc, if you're on a search and rescue team, you want to talk to the doc, all that stuff could be done in cool avenues like this.
Justin, we did use a civilian's drone to search out a guy who'd walked up a canyon in the snow, and it was just impossible to, it was impossible to track him. But a civilian had a heat-seeking drone, and they found him.
What is this civilian doing with a heat-seeking drone? That's what I want to know.
Listen, Andy Dietrich has everything. Andy Dietrich has everything. Andy Dietrich jumps off a boat onto a whale that's got a bunch of fishing line off of it and cuts it all off and then gets back in the boat.
Who is this dreamboat?
He's impenetrable. He's my friend's husband. He did search and rescue like maybe near Juneau, or maybe it was outside of Anchorage for a long time, and ski patrol, and he's just a beast, and he was out on our island for some time. But he's just like the man. He's not even, he doesn't officially do anything, but he just shows up and saves the day all the time.
That's excellent.
He's better than all of us. Like all my training.
Heart will take you a long way.
Hey, so I'm posting now. It's just an article that some of us put together. It's posted in the WMS about kind of how to get involved in research, how to start a project, how to get started with it. If Carver's still here, can you talk about how you got the program, how you got your funding, how you got your IRB approval, which you shouldn't need, so there were no patients, how you got all that stuff started?
Well, we did have to get an IRB exemption because any research we do through our institution, we either have to go with a full proposal or do an exemption. So I basically had to fill out a bunch of paperwork that said we're not using any human subjects in 10 different ways. And then they said, okay, you can go do your thing. As far as funding, didn't need a lot of funding for this, pretty much all self-funded. Already had some radios. They're like $25 a piece. The little cable that goes in between them was like $15. So didn't really need any funding, and then had a bunch of cool wilderness people volunteers who helped do the study. Steph LaRoe and CJ Wasdorp. So I can't speak to a ton of that. I made it easy and I avoided all the red tape.
And that is one of the things that it's getting better. Like since I started being a member of the WMS in 17 or 16 or something like that, it's definitely gotten a lot better access to resources and how to get started in research. There's a lot more help. There's increased mentorship. There's a lot more resources available to just like follow step by step almost. So it's just another plug for the WMS, I guess, is you can just go through it and just find cool projects people are working on, like people like Carver that just do projects like this. But if you're involved and invested, you can definitely get to be wrangled into a project like this, or just do your own. Is Prajwal here to talk about our next article? Yes. All right.
Yeah.
Perfect. While you get set up, thanks Sarah and Carver for helping with that first article, and TJ, I'll let you take back over for the next one.
Now we have Prajwal. He's going to help us out with the other article about gel alternatives, improvising ultrasound mediums in the field. Take it away.
All right, sounds good. I have some slides. If it's all right, I'm just going to share those.
Sure.
One second. Okay, it's not letting me share. I think it's an issue on my end. I'll just go through it. I'll just talk about it.
Okay. What a bummer.
Yeah. If it's okay, I can exit and rejoin, and that might let me do that, but I don't want to waste everyone's time too much.
That's fine. Go for it. I'll buy you some time. I can blab about stuff.
All right. Sounds good. Hey, can you see it now, actually?
Oh yeah, actually I can see it now.
Yeah.
Okay, great. Okay, I guess we're good.
A beautiful flower.
Awesome. All right. Does it look okay?
Yep.
Great.
Perfect.
So yeah, my name is Praj. I'm a first-year resident at St. Louis University. I'm going to be talking about this article, comparison of commonly carried liquids against commercial ultrasound gel for use in the backcountry setting. So why were these authors interested in this? Because largely in these austere environments, these backcountry settings, ultrasound might be the only imaging modality that's available. And this is largely because it's lightweight, it's durable. Now they're coming out with these probes that you can connect to your phone or your iPad. So it's a really practical way to image and make decisions about how to manage a patient in some of these settings when you don't have an X-ray or a CT. One of the caveats is that you need a coupling agent. And so a coupling agent is something that you need to transmit the sound from the probe to the patient, or basically through the patient's skin to see whatever it is you want to see within the patient's body or underneath the dermis. Typically in hospitals, you'll see this commercial ultrasound gel, this aquasonic stuff. It's nice because it's easy to apply. It's easy to clean off the patient. It slides around easily. But some of the cons is it can get bulky if you have to carry a lot of it. And it obviously has a cost associated with it, so it's slightly expensive. So therefore, it would be nice to have a cheap and readily available alternative that you can use in some austere settings. A little bit more about coupling agents. I was kind of curious about what makes a good coupling agent. Why is ultrasound gel the standard? Why do we use it? And what I kind of found is, through some personal research, is that the acoustic impedance of this gel is pretty similar to soft tissue. So what is acoustic impedance? That's kind of the resistance that the sound that's produced by the probe faces as it passes through different mediums. So if you can imagine, like, let's say you're standing on an edge of a canyon and you shout down into the canyon and then you hear the sound come back to you. Why does it come back to you and not go through the wall of the canyon? That's because there's a large difference in the impedance of the air and the material of the canyon, the rock. So this equation kind of breaks that down for us. It's the acoustic impedance of the medium is dependent on the density of the medium and also the speed of the sound through that medium. And it's also, you can also get some more information from the reflection coefficient, which is kind of the fraction of the waves that gets bounced back when you produce a sound. So the fraction that gets bounced back as the sound tries to pass through two separate mediums. So Z2 being the impedance of the second medium, Z1 being the impedance of the first medium. Basically, if the numerator goes to 0, you can kind of see that the reflection coefficient would go down to 0 as well. So that would mean all the sound is passing through and none of it's being reflected back. And that would be the ideal medium, ideal coupling agent, essentially. So that's why having a gel that has a similar impedance to soft tissue is so useful. And of course, this is only one of the factors that makes a gel useful or ideal. Other things would be the homogeneity, whether it reacts with the skin, the pH, viscosity, ease of cleaning, things like that. So now getting into the article a little bit. So what was their actual question? They were kind of looking into, can commonly carried toiletry and food products be used as alternative coupling agents to this commercial ultrasound gel to make a clinical decision when you do a point of care ultrasound. The secondary outcomes that they looked at were technical components of the image, including, we'll get into that in a little bit, and they also looked at the usability of the products. So the study design was a randomized interventional prospective study. They looked at a total of 10 gels, including the commercial gels. Some of them, I've listed them here. I won't read through all of them, but some of the interesting ones were maple syrup. They used sunscreen. They used Cliff Energy gel. And how the study was basically done was they had two sonographers who were EM physicians who were trained in wilderness medicine and ultrasound. And they used each of these 10 gels and they looked at 8 different scanning windows. So I've listed them here: right upper quadrant or left upper quadrant, pelvic, lung apex, peristernal long, peristernal short, cubital fossa, popliteal fossa. And they did this for 2 patients, or 2 subjects who are both of normal BMI, male, with no pathology. So this yields a total of 80 images, and they did it twice, so 160 images. And then each of the sonographers used a Likert scale to rate their experience with using these the gels. So they rated the gels based on their ease of application, how well they adhere to the patient, the ease of sliding, the ease of cleanup. That was rated on the Likert scale. Then they had 2 other physicians come in who were the interpreters, and they looked at the 160 images that were collected from scans for a total of 320 observations. And then what they did with how they collected data from the reviewers was, first, for the primary outcome, they made a dichotomous decision of whether or not the image could be used to make a clinical decision about the patient. So that was a yes or no answer. Next, they used the Likert scale to rate these technical factors of each of these images. So they rated each of the images based on resolution, artifact, and contrast on this Likert scale, 5 being the best, ideal. For the statistical analysis, the authors used a non-inferiority margin of 20%. And then they also did something else where they looked at something called a Krippendorf alpha, which is kind of to show that both of the reviewers of these images were similar enough in terms of like they weren't making wildly different assessments of the images that they were seeing. So going into the results for the primary outcome, so you can see on the chart on the left, what they saw was 94% of the images obtained with the conventional gel, with the commercial gel, were deemed as being adequate for making a clinical decision. On the other side of the spectrum, sunscreen, only 88% of those images were deemed as adequate for making a clinical decision. So based on their criteria for non-inferiority, based on their non-inferiority margin, the only one that didn't meet the criteria was, or that didn't meet the non-inferiority criteria was the sunscreen. And that's basically because they took this was like a new statistical concept for me, but they took this one-sided confidence interval. They looked at the upper limit of that one-sided confidence interval, so 97.5%. And then they took the difference of that between the percentage of the adequate images for the commercial gel. And if that difference was greater than 20%, it was that specific gel was deemed as being inadequate. So the only one that met that was the sunscreen. So it's pretty stringent criteria. And also, interestingly, it seems like several of these actually have seem to be outperforming the commercial gel in terms of generating adequate images that you can make a decision on. And those would be the olive oil, the syrup, the energy gel. And so for the secondary outcomes, this was a little different because it wasn't based on the dichotomous result, it was on the Likert scale. So the main thing I want to point here is the differences, the second columns in this table on the left. Basically, if it's a negative number, that means that alternate gel is somewhat outperforming the commercial gel because the difference is negative. So the difference between the commercial and the average and then the alternate gel average is negative. If it's a positive number, that means it's performing slightly poor or worse. But regardless of that, based on their non-inferiority margins, they found that on these technical aspects that they evaluated of contrast and based on the technical contrast, artifact, and resolution, none of them were inferior to the commercial gel. So that was kind of interesting, but we'll get into that a little bit more. And then also last thing that they looked at was the data from the people who actually did the scans in terms of the usability of the gels. And the main things here were all of them were pretty similar in terms of ease of sliding. They were all pretty equal in terms of sliding on the patient's body. The energy gel was more adherent, but it was more difficult to clean up. Water was less adherent, but it was obviously much easier to clean up. So some discussion. So like we mentioned, all the alternative gels that they tested, except the sunscreen, were non-inferior to the commercial gel to make the clinical decisions. They hypothesized that maybe the sunscreen was inferior because of the chemical makeup. And then for the technical aspects, all the substances were non-inferior to the commercial gel. So what that kind of suggests is there might be some unmeasured aspects that go beyond resolution, contrast, and artifact that could be affecting our ability to make a decision based on a POCUS image that we haven't that basically isn't included in these three technical aspects. So overall, the study shows that there are several alternative gels that don't require additional mixing or preparation or additional resources, that you can generate comparable POCUS images that you can guide your decisions with. Strengths and weaknesses of the paper. Strengths was, I like that they used a variety of gels, and it seemed like stuff that you would probably run into if you were in some of these environments, like Cliff Energy bars, soap, shampoo. I also like their stringent non-inferiority margin that they used. But some weaknesses were largely related to the external validity of the study. They conducted their scans indoors, which you might not always have the luxury of doing in some of these settings. They also completed the studies on males with normal BMI without any pathology. I don't have enough experience with ultrasound, but I'm thinking, if they do have some pathology, you might want to use the best possible gel, or maybe the type of gel you use plays a role in whether or not you can make the diagnosis that you need to. Also, their examiners and their sonographers were highly trained, so they might have been more comfortable with making decisions based on slightly subpar images. And then finally, the people getting the images were unblinded, so there's no real way to blind someone to whether you're using maple syrup to get an image. So obviously they might be altering their technique when they're trying to obtain the image, so that might also affect the results. But that was my thoughts about the paper. I liked it. It was very interesting, and with all the natural disasters going on, I think it's pretty important to come up with ways that you can get good POCUS images.
Absolutely. I'm glad the slides worked out. That was an excellent presentation. Thank you for putting the effort in.
Yeah, thank you.
Just off the bat, I'll open up the floor just to see if there's any questions, immediate questions or reactions floating around from the group. They do make mention about they're speculating about the suntan lotion, the sunblock, and why it didn't work as well. They mentioned the chemical composition, which I guess is probably the case, but I am also curious to see if they were able to figure out why that was the only one that didn't work well.
Some of them have minerals, like maybe it's a density thing.
Yeah.
Like they actually have more sediment in them, whereas like maple syrup and even like the energy gels and stuff, they're clear.
Like homogeneous.
Yeah. Whereas like most sunscreen has some sort of mineral backup in it, which I think would make it. I'm not a physicist. I can use ultrasound. I have no idea. People have explained it to me. I don't know how it works.
It's basically magic. It's like crystals. it's like fairy tale.
Yes, it's like somebody did something magical. It works, but I can only imagine that going through like more dense fluid would compromise the image.
That makes sense. I like this study a lot. I mean, it's nice to know that there's options out there, but I think it just kind of legitimizes some of the things that we do when we're out in the field, like just making decisions. I like that they've kind of formally published a paper that we can point to kind of allow us the breadth of improvisation. So I like that about this article. And it kind of goes for the first article as well, like the ability to come up with creative ways of solving these problems is kind of the name of the game when we're in the wilderness. So I like that a lot.
And you can eat it when you're done if you use this.
The sauce, right? Not the patient.
Let me just get you cleaned up.
Part of the reason I liked it was that it would potentially reduce the need to carry an additional thing with you if you're on a trip,
which is always the way.
It's always have multi-purpose stuff. So like the energy gels, you probably have that in your first aid kit or your own meal kit. And I thought it was kind of funny, the reasoning for having the maple syrup in it. For anybody read it, it's because I think it's Vermont. This just shows my geographical lack of knowledge. Dartmouth, I believe it's there.
Dartmouth, yeah.
Yeah.
I don't know where it is.
So it's actually in their search and rescue policy to have Vermont specific maple syrup in their search and rescue kit to treat hypoglycemia. So that's why they use it.
Was honey on the list?
I don't think it was.
No.
I can't remember. Yeah, I didn't see it. That would be interesting to try.
Yeah, any other from the group, any other suggestions of other things that maybe could be considered but weren't included in this study? Honey is a good one.
I can't stress this enough. It would probably never come off.
Yeah.
Corn syrup.
Right. You probably have. It'd be like a Tootsie Pop. You'd have to lick it 1,000 times.
You get it, you got a dog, you're ready to go.
There we go. Yeah, we need a copper in this situation.
I'm
Surprised they
curious
didn't try
about,
urine.
corn syrup or well, we have that water-based, like if you have any kind of the nasal trumpet lube.
Yeah, oh yeah. Well, I definitely reach for those little packets of those little sachets of lube in a pinch when I'm using ultrasound.
Yep.
Let's see. Hand sanitizer. Was that
Sanitizer was on there.
I think it was.
That was included.
Yeah, it was in there because most people have that in their kit too.
Yeah.
Did they specify if that was the gel or because I've met a lot of hand sanitizers?
It was Purell.
Okay, that's fairly specific.
And I know a lot of these ultrasound studies also, to use their equipment, they have to check to see what's the approved or specifically contraindicated material to avoid harming the probe. So in the studies, they're not going to use something that's going to damage the probe.
I think they made a note of that they were mindful of the equipment and the potential risks to the equipment or the patient. They tried to include only things that were, there's no evidence of harm should happen.
Just kind of like how when my residents or students leave the probe in the trauma bay just covered in gel and blood, just leave it dry and cake on there. It's just awesome.
No bueno.
Specifically, when you clean your probe too, you're not going to use, if you're in the clinical setting, you're not going to use the purple wipes. You're not going to use the bleach, orange wipes on your probe. You're going to use the gray specific or that spray. So you have to be really specific for what you use on it. Now, let's say you're in like a life or death. Yeah, great. Let's say you're in the life or death setting in the middle of nowhere. You probably use whatever you got. So the study's always limited by that kind of stuff.
I guess maybe that would add a pro to the Purell option because it's sanitizing at the same time. So,
and before they became really common, like when you're doing a central line, you have the long probe cutter sterile sheath.
mm-hmm.
Back in the day, we were just using tegaderms and just wrap it over the linear. It only works on
we were doing that too, but then just before I finished my training, they started telling us not to do that. I don't know if it was just because it just gets sticky and slimy, or if there's an actual threat to the device.
The manufacturer came through, or the salesperson came through and saw that we were doing that. They're like, "What are you doing?"
Seems like a good idea.
Part of me is wondering because I think it was the same person who sells the long probe cutter sheaths and he wanted us to use those instead. Mm-hmm. Just like in any study, you always look at where the author and the funding comes from. I was like, wait a minute, but you sell those things.
Follow the money.
So you could potentially get around using some weird substance. I use that loosely. If you have just a tegaderm just covered over, it's safer for the patient for infection risk and safer for the probe. But Vaseline or lotion. I mean, Vaseline is a pretty homogeneous thing. I think that
would work.
Lotion,
I think that would work, and I always have it for wound care.
Mm-hmm.
Yeah, it's really good for wound care. I mean, so is honey, be it bacteriostatic. Honestly, I don't know about lotion. There's like a billion different kinds out there, and I don't know. Well, that's interesting to see. I mean, this study could easily be reproduced with different coupling agents, different coupling agents or different techniques, because I think there was one specific landmark that they couldn't use for the whole study because of potential complications. But whether you have larger patients, smaller patients, there's truly no way to blind the performer, but you can blind the person reviewing it. Yeah, that was the list that was used, right?
Yeah, that was a list. So they had lotion on there, and actually they got more images that were actionable
There
using the lotion compared
Yeah.
to the commercial gel.
Yeah.
Somehow it works.
Yeah, very,
Like
very
that begs the
interesting
question:
results.
like, are any of these better than commercial gel? Like, they didn't really comment on are any of these preferable to using. They were just like, oh, they're as good is essentially what they kind of said.
That does actually bring up a point in general, in what I hope you all learn from journal club setting style critiquing of journal articles is the format and the methods used. So this was, as he went through it, if I'm not mistaken, essentially a non-inferiority trial, right?
Yeah.
Comparing it against a standard to make sure that these were not less like lesser quality materials. It's really easy to prove something's not inferior. This like the standard, the methods are much easier to get across. It's much easier to prove your hypothesis. It's a reliable study. It's a good way to show like, hey, it's just as good, but it's really easy to do that, to get that, what was it, 20% or 20? It's really
20%.
Not that that means this is not correct. Like this is right, but I think it would be then cool, like you suggested, are any of these better? And that would be much harder to prove. And it's strange to think about, like, why is it easier to show it's not less good than it is to show it's better? But it is mathematically, statistically a lot harder to prove. So this is a good stepping point. Like, this was the first one of this kind came out. I was hoping that it would be done in time, but a couple people from our group here at VTC are doing something similar. It's just not nearly as far along. So it'd be kind of fun to see in a year, hopefully less than a year, where that's coming along from. Has anybody used anything? I mean, in the hospital, like, you're going to use commercial gel or the little lube packets, right? Does anybody actually use anything else?
Water. I've done like the baths for extremities.
Yeah.
I've used like a tiny little like IV pack.
Oh, you just like set it on top? That's kind of
Especially
cool.
for the eye. Yeah.
That's a good idea.
Interesting.
Yeah, because
I've
gel
never
on the
used
eye,
it.
Just like the little 250cc one.
or like even a 50cc bag that they, yeah.
I might try that next time.
Yeah, me too. Because like the gel is always a pain. Sometimes I'll put Tegaderm
Let me
on the
know.
eye,
Oh,
but then you gotta peel that off. It's no bueno.
yeah. I know some of my coworkers don't use the Tegaderm over the eye. They just put all the gel on the eye. I'm just like,
Yeah.
just put the Tegaderm on. It kind of saves you some
That's
effort.
mean.
Yeah, I don't
Yeah,
hate
that's
my
mean.
patients. Most of my patients. I don't hate most of my patients. So
So like, part of the reason I chose these two articles, first off, because I knew the articles, both of them. I knew the authors of both articles. Unfortunately, the author of this second article had a medical emergency, was unable to attend, which is very reasonable. But it's always nice if I can get the articles or an expert to join. So it's if Carver's still here, I'm glad that he was able to walk us through that process. So these were just kind of like the next step. What can you do in the wilderness to do what we do in a typical clinical setting, or what can you use alternatively? I'm sure a lot of you joined to just learn more about wilderness uses of ultrasound in general. So Sarah was telling us some of her ultrasound use in Alaska and stuff like that, but does anybody have any questions about ultrasound in general, or how it can be used outside the hospital setting? Or just like experiences yourself you want to share?
I haven't done it myself, but I have seen, you can visualize defects in the cortex consistent with fractures and stuff like that, which is really cool. It's a really useful way of diagnosing fractures, and from what I understand, it's a pretty reliable way of diagnosing fractures. Oh, I think you're muted there, Sarah.
Yep.
Sorry. I can back that up, especially like with radial head fractures in the elbow that are difficult to see on x-ray. And even I had a negative x-ray on, I was sure this guy had fractured his fibula, and you could see it on ultrasound.
Very cool.
And there was just another either a study or an article posted on one of the ultrasound fellowship groups on Facebook, Instagram, but it was using it to find hip fractures.
Hmm.
I broke my toe a couple years ago, and one of our faculty really wanted to ultrasound my foot to show if it worked. I was like, I don't want you touching my foot; it hurts.
The hip thing though, because of how you use the ultrasound to like inject into the hip, you absolutely could see if somebody had a femoral neck fracture. That's brilliant. Never even thought about
you can use it essentially for any long bone. Again, you got limitations based on body habitus, muscle mass, location of the injury, other injuries that could be capable. But I mean, fast exams. If you don't know what that is, focus assessment in
Sonographic trauma.
Trauma is the last, but I can't remember what the S is, but it's probably sonography. Focus assessment with sonography and trauma, I think. But you're basically looking at all the quadrants of the belly and then a heart, lung sliding in both lungs to check to see if there's technically it's to check for blunt trauma that would essentially lead you to go straight to the OR. That's what the actual study was done to show its use, and that's what it's actually indicated for. A lot of programs and hospitals use it for penetrating trauma. Not indicated for penetrating trauma. We just use it because that's what it's stuck in our heads. And it helps your learning. You stay in practice if you keep doing it. So, I mean, you might delay care a little bit, but but it would be great. Let's say in a rock climbing setting, your buddy falls down and you just notice like, hey, he's looking kind of shocky. You raise his legs, something's still weird. And then you start ultrasounding his right upper or heart or right upper quadrant, whichever one you start first. And then checked between the liver and the kidney. You check between the spleen and the kidney on the other side. You check around the bladder. You check around the heart. You're looking for pericardial effusion. You check for lung sliding, which is literally like you see the lung sliding between the ribs. That way you know if there's a let's call it a large pneumothorax or not. You might not find the tiny ones. And there's studies on that. I don't want to go into the details about how big the pneumo has to be defined by ultrasound. That depends on patient and body habitus, the size of the pneumo, and the person doing it. But the main thing is to see, hey, there is free fluid in the belly. We got to go straight to the OR. But that can be really useful if you're in medical race support. You'd have to fall pretty hard if you're in an ultramarathon to do that. But rock climbing, search and rescue would be fantastic. Like there's been multiple cases since we live here in Virginia along the Appalachian Trail. Unfortunately, people fall off of really famous parts of the AT called McAfee's Knob, Dragon's Tooth, and there's been multiple deaths over the past couple of years. And I actually believe they were portable ultrasound was used in those settings. Can't confirm 100%. I wasn't there. I was in the ER at the time. Saw the patient come in, but I wasn't in the field. But you can also use it for eyes. I love using it for eye exams. Look for vitreous detachment, retinal detachment. Let's say you have a sudden vision loss in the field. You can check to see if there's a retinal detachment. Granted, you want to know if there's an open globe injury first before you start pushing on the eye.
Never push on the eye if the little black part looks like it's been popped.
So you do the other things. Like I essentially, and a lot of ophthalmologists now think of essentially three things as the ABCs of the eye or the vital signs of the eye, which are visual acuity, makes sense. Pressures, makes sense. And then ultrasound. You might want to do a fluorescein stain, do a full foreign body assessment and extraocular movement exam before you do an ultrasound. As I've found some very interesting open globe injuries that are really high up on the eye. And if you don't really look thoroughly, you might miss that. Granted, you should see some weird Seidel sign fluid straining over the eye on fluorescein. And for students, that's the stuff that looks like the predator blood or the alien blood from the movies. It's you put it in the eye, it turns green under blue light or black light. And that's how you know if there's uptake, meaning it sticks to part of the eye. It shouldn't stick to the eye. If it sticks, there's an injury, a scratch, a scrape, ulcer, or a penetrating wound. So do that stuff before you do ultrasound of the eye. but you can check for fractures. One of my coworkers uses ultrasound, I think, for every single patient he's ever seen. Fellowship trained. He checks to see shoulder dislocations. He does a pre and post ultrasound. I think he's done away with pre and post x-rays. He's doing pre and post ultrasounds to check reduction success. I'm not good enough to find that. He's also using,
And they don't like it when you touch them.
no.
Like you said, like, don't ultrasound me, it hurts.
Yeah, it hurts. In the ultrasound, you don't want to push hard, but sometimes you have to. If you're looking at subxiphoid, which is subxiphoid process right here, you got to push in hard. And a lot of people, we live in Virginia, they're Virginians, you need to push hard to get a good view of the heart. They're very useful. You're not going to bring a portable x-ray. You're not going to have a portable CT. And literally these little devices are this big. And the probe plus the probe is like, a pound. So it doesn't take up extra space at all, basically. Have
you ever used it for rib fractures, Justin? I never have tried. It just occurred to me as you were saying all that.
I haven't. If I'm doing an ultrasound of the chest, I'm either looking for lung slide, pulmonary edema, or like pericardial effusion, or like a vegetation on a valve.
But I don't see why you couldn't.
I think you could. I think somebody
that'd be a great target.
I might do it next time just from my own knowledge and just try it. I just have not done it myself.
If someone does it before I do, let me know.
Granted, again, a lot of my patients have got they just got in a horrible car crash and they have clearly a couple broken ribs, and we're checking for lung slide quick and then we're done. I might do it once they're out of the trauma bay in a regular patient room with some fentanyl on the board, and then I'll check their ribs. And I think it'd be kind of cool if you see the CT or X-ray and you know what's broken, and then just for your own practice to go through and be like, hey, I can see it, and then take the next step and use it in like an actual diagnostic setting.
Maybe with maple syrup.
When I was thinking, granted, we could go over the actual statistical and like quality of study with these different fluids. If I was going to use any of these myself, like the hand sanitizer, the energy gel, the hand sanitizer, or I suppose if I'm search and rescue in Vermont, the maple syrup, all multi-purpose, I think I'd probably choose one of those.
Apparently, I mean, they used water too, right? And water did pretty well.
Water bath is essentially the standard. It's hard to be a pure water bath. So if you have a stream or like a pool with no sediment, put an extremity.
I was assuming that the tap water they used was probably based on the images they were collecting, was like just poured on and they just applied the probe on top. I don't think they used a water bath for the tap water that was included in the study, right?
Oh,
I think they just splashed some water on. I don't know what they did.
Did you see that? I don't know if I noticed their means of the patient wet, other than just re-wet.
I think they made a note about, they were discussing water baths and how that's impractical unless you're using extremities.
I don't remember exactly. I think you're right. They did say that water bath is the best way, and it wouldn't be ideal for the thorax essentially.
Yeah.
In the abdomen. Yeah.
So they must have just splashed a little water on. I don't know.
Mm-hmm.
We'll try that in the trauma bay too. Hold on, guys.
If you have that much water, you're probably not far from the trailhead or an ambulance capable site anyway. Most people backpacking don't have a gallon of water to trickle over a patient and do an ultrasound. I don't know how much water you guys carry, but I don't know if you're doing a prolonged cardiac ultrasound. I just did one yesterday. I found a very large pericardial effusion with tamponade physiology. So I was looking close, I was of course at my critical access hospital. It's always there.
Did you put a needle in there?
She was stable. She had early tamponade. I was
ooh, spicy.
So I was I had my NP run out of the room, get that transfer center on the line. But like, you go through gel quick. It's surprising how much gel you end up using sometimes. So if you're in the field, like, I guess try and be careful about how much you have, because you probably don't have as much as in the hospital setting. You have the Praj, you had like the biggest jug of gel I've ever seen in one of your slides. It was like a tub, but nobody has that in the field. So
Yeah, I just wanted to include that so you could see what it looks like inside. I didn't see like any pictures of the blue stuff, but
yeah,
like I'm on my ultrasound rotation right now, and I'm always carrying like 5 or 6 of those little packets, and they like keep falling out of my pocket. I'm like, yeah, this is definitely not a good thing if you try to do it in like some weird place.
yeah. So the fellowship trained people are doing some pretty high level stuff that I just don't personally have experience with. But I had a horrible necrotizing fasciitis patient recently, and I told my ultrasound friend, and he came running. He's like, "Oh, I just want to see what it looks like on ultrasound." He just was like, "Okay, I'm here getting this patient rushed to the OR, but yeah, sure." So I think it's definitely coming on more and more residencies and students. Like, I know some programs like first semester med school, and again, talking from a med school experience, because that's my route. I'm sure there's ACP nursing and everybody here, getting ultrasound experience early on. And the earlier you can get trained with it, the easier you do. Like, and a lot of our nurses are now doing ultrasound guided IVs, and if you train later, it's kind of like taking a step back to learn ultrasound and then move forward with the procedural component. So learn the basics earlier on if you can. There's a lot of courses. Most hospitals teach, if you're a nurse or ACP or like medic, a lot of programs now have a way to at least learn how to do it for an ultrasound guided needle placement, and that just gets you familiar with it, and then you can take it further. But at the end of the day, like a good old interosseous drill, never fail with that. Especially if you're in the trauma.
There was one study that said it was superior to even a central line because it got in quicker and there's less capacity for trauma. And I mean, I don't think we're going to be able to get like the modern medical community away from the central lines and stuff like that. But I could find that article for you. There was one that said,
yeah, it's slightly off topic, I suppose, but I've been in a couple cases where there's like a crashing patient, the nurse can't get the IV, and my resident's running for the ultrasound to do an ultrasound guided line. I'm like, just get me the IO drill and get this in like 1.5 seconds. And I just wanted to take that caveat. Ultrasound is fantastic. It does not take place of a good physical exam. It does not take the place of experience or your just clinical assessment. And don't do an ultrasound just it is a diagnostic purpose if you're like in a setting of an emergent life or death, like time is, you could lift off all the organ settings or time is something, unless it is like, testicular torsion, you could do bedside and know if there's flow, but that's clinical too. So doesn't take the place of a good clinical exam. I've definitely seen people focus on it too much. And as an attending who teaches residents and students, I've definitely seen that become more of a thing over the past few years. And just remember, your basics come first. And if ultrasound is a basic for you, you'll get better with it. But also remember the basics. Like what Sarah was saying, I learned how to do a femoral central line blind with just landmarks and knowing where the pulse was way before I did ultrasound. Because if you're in a crashing patient situation, you're not going to go find the ultrasound and try and find the femoral vein. You're going to poke. So just remember that it's an adjunct. It's a great pre-hospital thing. It's a great in-hospital thing if you know what you're doing and you're not delaying other care or just good clinical sense. Again, talking from a non-fellowship ultrasound trained, just did a regular old 4 years of residency, year of fellowship in wilderness. Any questions about ultrasound, or if anybody is wanting to talk about one of our 2 articles further, just speak up now. Okay, I'm going to end the recording and we can talk about anything else you guys are interested in as far as like the actual content of this session on wilderness ultrasound. We can call this coming to a close. But if anybody wants to talk about WMS, wilderness medicine, research, FOM, DIM, DIDM, I've done it all. So, and so is our fellow here is on that route too. But thank you, Sarah and Prajwal, for helping us, and as well as TJ, our fellow, for leading a session.
Thank you, guys.
I'm going to end recording.
I
Thank
wanted
you,
to show
Justin,
you
for
guys
organizing.
something.
If I can find it.
I wanted to show you guys something.